fungus, yeast. We're going to talk about hair and nails. And last, well, not last, but close to the last, we're going to talk about the bugs, right? We're going to talk about the bites. We're going to talk about the infestations. We're going to talk about all of those things out there, okay? I'm not going to say that it's easier than what we did in block 1. It's a little bit more stuff that's out there, okay? We'll have, half of the test will have those pictures, and other things that are out there. We'll see some of those medications, the prescriptions, those things. Again, just like in block 1, we're going to go oral, we're going to go topical, we're going to go IM, we're going to go medication-wise, but just like the dosage, I'm not going to push on dosages, okay? Y'all are going to figure this stuff out, right? I still have from, I'm old, started in, 2010? Building up a Word document that I saved what I would do over and over and over and over and over, and I would do that exact same thing. So again, I'm going to test you the exact same way that I did for block 1, in block 2, and block 3, okay? Again, all the answers come out when I'm standing right here, and so that's the reason why I like to push that stuff out. So we're going to start off talking today about the bacterial stuff, but then we're going to get into the fungal and yeast stuff after we take a break, okay? All right, so look at the list of the things bacterial. It's not small. There's a lot. So we're going to talk about the 2 types of impetigo. We're going to talk about cellulitis, erysipelas, blister, folliculitis, boom to the boom to the boom, boom, boom. Okay, we're going to talk about all of these things as we go through them. Okay, again, just like what, I don't know how Commander Grande is so loud, but I feel like I'm loud. I'm baby boy at the Super Bowl. All right, let's turn it down a little bit. All right, good. Okay, so here we go. Skin infections, okay? We can see there is one type that is first. This is so loud, it's weird. But right here, aureus. Aureus is a key component. Turning this down, I don't know if it's going to work or not, but not only Staph aureus is there, we also have group A beta hemolytic strep. These are those infection things that happen out there, okay? Staph aureus, I like Staph aureus because that's pretty much invades the skin and cause impetigo, folliculitis, cellulitis, furuncles, right? So that's one of a main spot that causes these things to happen. Yes, Group A is out there. Group A is specific for one of these things that are going to come up, but Staph aureus is one of those things out there that you will see, I promise. So it breaks it down into those things, okay? That's the first slide that just talks about those infections. So let's break it down, okay? We're going to start off with non-bullous impetigo. Non-bullous. Primary is what I just talked about, right? That's that aureus. You can also have it be that beta hemolytic streptococcus, but the primary of non-bullous impetigo is staph. Starts at the stratum corneum pustule or vesicle, ruptures, expose a red moist base. Basically, you've got that honey-crusted weeping lesion. Okay, we see this on kiddos. Again, y'all are going to go through this once y'all get into peds. 2 to 5 years old, as I said, most common in kids. High frequency in warm, moist climates, associated with poor hygiene. Regional lymphadenopathy is common. So not only are they having that honey crust, but they could be having some of that lymphadenopathy as well. Picture, we can see that is of the chin, of the nasal labial areas. Okay, it's that honey crusted thing that is there. Okay. Treatment wise, we're going to do that cool or warm soaks to remove crust. Okay, of course, we're going to do that with everything. But antibiotics, okay? Right below that antibiotics, it breaks it down into topical and oral, okay? So if it's limited, meaning you're only seeing it in one spot, then we can use the topical Bactroban, okay, so that mupirocin, if it's limited. However, if I tell you that it's widespread, then we're going to go oral. So we can use dicloxacillin if they're not having a penicillin allergy. If they are, if mom tells you that he or she has a penicillin allergy, then we're going to go oral Keflex, so cephalexin. Okay? We're talking about of the medications used for non-bullous impetigo. Okay? Is it limited or is it widespread? Those are those things for you to know. I might even use the word widespread. Okay? So there you go. We also want to prevent acute of the kidney stuff there, right? Because you can have some of that glomerulonephritis after impetigo, so that's one of those things that is a key component, is to prevent that. Dressing it, don't spread it. There's that honey crust, right? Lower chin, lower legs. Again, non-bullous impetigo. What does non-bullous mean? It's not having that bulla, right? So it's non-bullous. Yes, it's going to look the same as bullous, but with bullous, it gets more into that bulla, which is what we're going to talk about next. So, staph again. Common, any age, most common, infants, adolescents, again, peds. It's bullous, so it's got that less exudative crusting. One or more vesicles enlarge rapidly to form the bullae, turn from clear to cloudy, center collapses. Just like the non-bullous, it's still got that honey crust. It's got that honey, yellowish crust. It's different than the non-bullous because this is bullous. So it's got that bullae, right? So you get that moist base. It can ooze. You can get that stuff coming out that you're looking at. Treatment again, just like before. Warm or cool soaks. Antibiotics, it's the same. Mupirocin, right? So that Bactroban, topical ointment if it's limited. If it's widespread, we're getting into those same things out there, right? Again, diclox is probably the number one, unless they have a penicillin allergy. Then we're going to go into cephalexin, erythromycin, clindamycin. Those things are out there. There we go. We can see how we got that honey crust that is there, but it's bullous because you get some of that bullae, like you've got some of that ooze, that stuff that's coming out, that pus, that nasty. Okay, there we go. Again, we see that ooze. Dun dun dun. No bueno. Okay, if you've had it, it can come back. Okay, if you've got that infectious process, if you got that Staph aureus, then it can build itself back up. So patients with recurrent impetigo should be evaluated for carriage of the Staphylococcus aureus. Culture and treat with mupirocin if found. Okay? All right. So that's the impetigo. We got non-bullous, and then we've got bullous. Staph aureus. Cellulitis. Skin infection that extends into sub-Q. So subcutaneous is where that cellulitis begins. Okay? They will have erythema, so they'll have the redness. They'll have edema, swelling. They'll have pain. Okay? Etiology. This one's different than the bullous two, right? This one, most common, is that group A. But you can also have staph, you can have influenza, you can have pseudomonas. Diabetics, like if we ever think about diabetes, like pseudo should be right there next to it because they run together. They're like co-partners. They love it. Okay? Pseudomonas, diabetics. More common in areas compromised by stasis or lymphedema. This is where that cellulitis happens. So how do they present? Okay, I said red, swollen, diffusely warm and tender. Like if you were to put the back of your hand onto that area, it's warm. Thank you for putting the heater on because it's right there. Okay, that's where you will feel. Poorly defined border. What does that mean? That means you see the redness and then it fades away. It's not like you can see exactly, it's right here. That's where the border's at. It just spreads out, so it's not so much of a border that you can see. We can have some of that streaking lymphangitis, so red streaks and swollen nodes. Cellulitis can also have some of those vesicles, or it can be bullae that are there. Okay, because it's going to be pressing it out, so you can see that. Patients also present, with the fevers, the chills, the white blood cells are elevated, right? So their CBC is high. It's showing you infection is there. Okay, all of these bacterial infection stuff, WBCs are going to be elevated in all of them. Okay, because that's your body responding to having that Staph aureus or that group A or those things to show up so that you can see those things. Again, cool compresses. Okay? A key component to cellulitis is about their well-being. Okay? Well-being. Are they coming to your ER and they're unconscious? They're, just out. They have that altered mental status. If they have those things, we're going to admit them, right? So if we need to have them with the fevers and the chills and their AMS, like we're going to go inpatient, so we're going to go with IV Cillin. If they have that allergy, then we're going IV Vanc. But if they are having good mental status, if they're not having the fever, if they're just hey, I don't know what the hell is going on with this right here, but if they're going to be outpatient, then we're going to give them PO meds. Okay? Again, in a vignette, in a question, I will describe a patient to you, and you will decide, should I admit them or should I let them go? So that's inpatient or outpatient. Key component. Okay? I talk about those individuals who have diabetes, right? Pseudo is diabetes best friends, right? They love each other. They all flow together. Y'all, we're going to talk diabetes and pseudo a lot throughout what we're going through. Okay? If they do have that pseudomonas, then those cosides H. flu, then we'll do some of that cephalosporins that's there, okay? Again, with this slide, the key component is inpatient versus outpatient. And that's how they look, right? We can see that spot. That's that spot right smack in the middle where we see that pushing out. So that's that redness. If I were to touch it, it would be warm. We can see that, yeah, there it is. Can we see the border? No, because it's just fading into that. Yeah, that's red, that's hot, that's this, that's that. But that's what they look like. Okay? There it is again. Redness. Cellulitis. Okay. Something that is similar, but a little bit different, is erysipelas. Okay? Bold and underlined. That's that sharp demarcation. So you can see the borders that are there. You see where that redness is a little bit different than cellulitis. Okay? You can see that happening. So erysipelas, aka St. Anthony Farr, superficial cellulitis of lymphatics. We see that we've got a strep here, but this one is pyogens. We've got that redness, the swelling, the pain. Usually this occurs on the face, ears, legs. Prodromal symptoms last 4 to 48 hours. Like I said, we got that slightly raised plaque with sharp demarcation. So you can see that border more than before. Patient is sick. So malaise, fever, lymphadenopathy. Of course, CBC is going to be high, positive, right? So we're going to get that elevation. If we're having this erysipelas, okay, systemic antibiotics orally or IV, depending on the patient's status. Just like what I talked about in the cellulitis, are they inpatient or are they outpatient? Again, fevers, mental status. We're looking at those things to say, hey, you're in my ER with me right now, so you're going to say, or I'm going to give you something and you're going to go. So if we're going to do oral, then amoxicillin, Keflex, Diclox, depending on that allergy stuff. But if they're going inpatient, then IV of cefalozin or ceftriaxone. Those are the medications that we use here, right? We're talking about all of this bacterial stuff. There's going to be a lot of antibiotics, okay? Because we have to treat that. Picture-wise, you can see that there. You see that sharp demarcation. You can see that border where it's at. It's not fading, it's in that spot. Again, of the face. So not only is he having some of that redness of the lower eyelids and upper cheeks, but he's having that swelling, redness, painful. It's there. Again, there you go. So now let's get into some of that blistering. So blistering distal dactylitis, superficial infection of anterior fat pad of the fingertips. So it's at that area of our fingertips. Faint redness, vesicles to oval. You can have that, some of that bully, that exfoliation. Most common in 2 to 16. Treatment, what are we going to do? We're going to cut it. If we've got that blister distal dactylis, we're going to IND. And then, of course, we're going to prescribe some anti-strep oral antibiotics that they're going to take for those 10 days to make sure that it doesn't get worse. Again, fingertips. There we go. We see that toe there is swollen. It's red. So it's not only on our fingertips, can be on our toes. So that's blistering distal dactylitis. Folliculitis. Folliculitis. Inflammation of the hair follicle. Okay, we went over PFB, and we know that that's folliculitis, right? So that's that infection that is associated to that hair follicle. Not only can it be because of staph, it can also be chemical irritation, it could be a physical injury. Those things are out there, right? So talked about staph folliculitis, that's the most common. Nares are common reservoir for staph. So those nares in and around of our nose could be that reservoir. Seen with occlusion of follicles on face and scalp with oils, grease, makeup, that can be out there. Tiny follicular pustules with undamaged hair in the center, that's that superficial folliculitis. How are we going to work it up? Of course, we're going to take all of those cultures. Okay, so we're scraping off that entire pustule with a 15-blade scalpel and deposit on the cotton swab and transport medium kit. So that's what we're going to be doing to send it over to the lab so that they can make sure that we're treating the underlying infectious process. So prove that it's that. Removal of occlusion, irritants, yeah, like let's take that bad stuff away. Okay, skin hygiene. We see that oral antibiotics, right? Mycins are loved. So erythromycin, clindamycin, Diclox, Keflex, cephalexin. We can also add some of that benzoyl peroxide that all of y'all love to use for initial treatments of that acne. If this is persistent or it's deep, right, then we're going to get into those systemic antibiotics up to 4 to 8 weeks. We're going to talk about folliculitis declavans, and that will be something further on that we would want to use as well. So there's that folliculitis. So that hair follicle, shaving area, So I just talked about how we would want to treat if it's that Psychosis barbae. Well, here it is, okay? Inflammation of the entire follicle. So it's not just a single folliculitis. This is widespread, okay? This is inflammation of the entire follicle. So it's not just one spot, it's more. Staph impetigo of the bear. Razor spreads infection follicle to follicle. So change your razor, damn it. Treat same as staph impetigo, so we're using those oral antibiotics at least 2 weeks. If it's severe or that first line antibiotics aren't working, then we can look for dermatophyte infection. We'll be doing that culture stuff so that we can then make sure that we're treating it in the appropriate way. So it's not in just one spot, it's spread. So we can see it's not just one follicle, it's multiples. Again, we see all that beard area. Okay? So your question might be about some type of man who's having this stuff, right? Okay. So, we've got furuncles and carbuncles. So I teach this and I usually throw it out there how your uncles are at the bar and they get in the car, right? So if you have one uncle, that's a furuncle. If you have multiple uncles, they're in the car, okay? So if there's two uncles, car. So multi-headed boil. If it's just one, if it's just by itself, then that's a furuncle. So there's a difference between furuncle and carbuncle. So these things are those boil abscesses, okay? You get that collection of pus. They're hurt if you press on them. They have some of that firm, fluctuant mass. These can be associated with what we talked about when we were speaking about of that cellulitis, right? So cellulitis can have that uncle that is there. Both are painful, parafollicular deep infection of the hair follicle, most common in friction-prone or traumatized areas. So our thighs, our butt, groin, axillary, waist, those areas that are just irritating and inflaming that to happen. Treatment's the same for both, okay? So the primary management of a furuncle or carbuncle is I&D, right? So we gotta stab it, get that stuff out. Moist heat to localize and spontaneously rupture or to ease that I&D. Oftentimes, if y'all are seeing this, y'all will put a warm pad onto them as they're spending some time to loosen, to heat it up a little bit so that it's not as firm, and then we can cut at it. Systemic antibiotics not necessary after I&D, but speed healing and prevent reoccurrence. We're going to give them some PO antibiotic afterwards just because we're stabbing into that. Yes, they have an infection that's going on, but we could, put more in if that were the case. So is that a furuncle or a carbuncle? That's a furuncle, right? So that's one. That's right smack in the middle. Y'all can see where we're going to stab at. What is that one? There's at least two of those things that are happening there, so that's a carbuncle, right? So you can see where that is pushing out. Those uncles need to go back to the bar and get taken to jail or something, because there's a lot of them out there, okay? Don't drink and drive, damn it. All right, so that's furuncle and carbuncle. MRSA, common especially in those recurrent furunculosis. Consider antibiotic treatment and declone them. So if we're going to do some of that, Bactroban, so mupirocin twice daily. We can also add in some of those cleaning stuff, right? So you get that chlora, we get that dilute bleach baths. We've got those things to add in there. Depending on what the culture and sensitivity is, then we can look into some of those other antibiotics there. So up top, that's called what? Septra, right? So try sulfa or clindamycin. So that's MRSA stuff. SSSS, Staphylococcus scalded skin syndrome. So this is that Staph aureus. I love Staph aureus. So we've got blistering disease caused by Staph aureus exfoliative toxins. Oftentimes SSSS is seen in those infants, those kiddos, young children. Decreased renal toxin clearance. So of course it's going to not only affect the skin, but it's going to get into our kidneys and stuff. So that's that aspect of SSSS. Yeah, so it's spreading out in our blood, right? So we got that generalized effects. Typically starts with bullous impetigo in kids. So this is of that differential diagnosis. If we think that this is some type of impetigo, then impetigo can have SSSS associated with it there. So those are those things that are out there. Prodrome, they got that malaise, they got that fever, irritability, and tenderness of the skin. A key component, let's add another S. So instead of 4 S's, let's add a 5th S. could be that fifth S? Sandpaper. I saw that. Good. Sandpaper. So it's got that sandpaper-like texture, often insinuated in the flexural and periorbital areas. No involvement of the mucous membrane, so these S's are not in our mouth. Within 1 or 2 days, the skin wrinkles, forms translucent bullae, and peels off in large sheets. So it's the same Nikolsky sign. What did y'all pick for Nikolsky on test yesterday? 10, right? So this is similar to 10. So this can be of a differential diagnosis because it's got Nikolsky sign just like 10 did. Of course, clinical, we're going to do that biopsy. We're going to check to see if this is some of that Staph aureus that is out there. Treatment-wise is dependent of is it severe or not? If it's severe, then of course we're going to admit them. We're going to do those antibiotics. If it's mild, then we can use Diclox, we can use cephalexin for 7 to 10 days. Again, this is going to come up when y'all get with Lieutenant Colonel Select Klein. I think y'all might know her. I don't know. I'm not sure. She loves y'all. Kiddos, right? So this is going to come up in peds. So we can see that Nikolsky sign, right? We got that skin that's peeling off, and it's because of that area. Talk about those locations. So we see genital, we see thigh, we can see flexural areas, right? So that's that there. Another kiddo. Okay, so SSSS, and then we'll add that fifth S of that sand, right? Okay. Up next, we're going to talk about Pseudomonas aeruginosa. What did I say is a key component of pseudo? Diabetics. Look, bold and underlined. Pseudomonas aeruginosa. So we've got that gram-negative organism. Diabetics. Warm, moist areas. So inguinal areas, right? So underarms, groin, back and forth. So anal genital areas. You can even have this in your ears, right? Those are moist and warm. One of the things there is if we were to do some type of a woods lamp and we see that light green, that's pseudo. It'll have that fruity grape-like odor, okay? So it smells like you're at the market, right? So we got that fruity grape-like odor with Pseudomonas aeruginosa. Again, talked about that woods lamp, right? We see that light green fluorescence that is there. Another Pseudomonas will have that folliculitis. So the hot tub, okay? You're on vacation, you're out partying, having fun, okay? Occurs in water, not hot enough or chemically treated well enough to prevent that growth. Infections 8 hours, you could have it a week after you were there. Of course, we know occlusion, right? So that's that groin, that abdomen, upper belly, upper of the breast, axilla, those areas sweating. Develops multiple pruritic round urticarial plaques with central papule or pustule. So that is a hot tub folliculitis. They can have some of that fever, they can have that some fatigue, so malaise, okay? And it's not like that other 10 and SJS So it's not generally at risk for sepsis. That's that hot tub folliculitis. Usually self-limited, okay, so it will go away. It's a Pseudomonas, but it can take some time, okay? We can use some of that antihistamine if it is itching. Localized. Acetic acid. Okay, so we can do some of those vinegar soaks. More involved or severe, ciprofloxacin. More involved, severe, we get into Cipro. Again, I don't ever go with those dosages, but the name is important. So Cipro. Would that be just a picture of an individual who has it localized, or it's a little bit widespread?
Widespread?
A little bit widespread, right? So we would think Cipro. Should I say it again? Okay, all right. Again, Pseudomonas. So this is specifically now Pseudomonas cellulitis. So commonly found in debilitated or diabetic patient. Diabetes, damn it. Pseudomonas. Secondary invasion of tinea and toe webs or groin, fed sores, stasis ulcers, burns, grafted areas under of the foreskin. So if it's not a male, they can have that there. Soldier in a swampy environment, right? So you got all of that moisture, you got that nasty water stuff stuck in your boots, okay? You can also have that external otitis, so a outer infection of the ear. Said it again, diabetes. So of course we need to always check if we know that they have diabetes, or if we assume that it could be diabetes, we're always going to get that blood sugar just to see what it's looking like. Acetic acid, talked about that vinegar before on that other one. But if we're having it widespread, if we're seeing some of those comorbidities, if we're seeing some of that fever, chills, nausea, vomiting, if we're seeing those symptomatic process, then we will get into those systemic antibiotics. And pseudo-Cipro. Okay? So that's that. What do they look like? Ew. Ew. Talked about the ear. Okay? It can also not only be on those extremities or those outer places, it can be stuck in the middle of your toenail area. Okay? So that toe, again, Pseudomonas toe web infection between the 4th and 5th. So that pinky and that 4th one can be that. Thick, white, macerated skin. If we use that Woods lamp, every pseudo is going to be green. Pseudo green diabetes. Cipro. Just put those words together. Right? They're all best friends that are out there partying. Yes, we're talking about the bacterial stuff, but this can also be some of that fungal or other bacteria that are out there, okay? Treatment-wise, keep it clean and dry. So we see that we've got that dry sol, so that's that hypohidrosis, so it's breaking down that skin break because of sweat. We can use gentamicin cream once it's dried. But, of course, I've said it numerous times, Cipro. If it's pseudo, Cipro. Pseudo-Cipro. Got it. Trichomoniasis axillaris. So that's that Corynebacterium. We see that in the axilla, the groin, the web spaces of the toes. Again, that's that wet area. Hair of the axilla, whitish of colored hair. So it gets more whitish. So if you're looking at that hair of the axilla, it'll look like it's got some cream in it or something, but it's that whitish discoloration. All caps, very nasty. It stinks, right? You'll be like, all right, lift that arm up. I'm looking at it over here. I don't want to get close because I don't want to smell your armpit. All right, treatment-wise, shave that area. Okay, we can use some of that topical erythromycin or clindamycin. We can use that topical Naftin. So that's we use that if it is some type of a fungal thing, but it'll work with this there. Stop the sweating, okay? So control that hyperhidrosis. So that's that dry sol that we talked about. Okay, let's go with Dove. Yeah, sweaty stuff. There's a picture of it. We see that whitish of that hair stuff there. Stinky. Da-da-da. Almost break time. We're almost there. Erythrasma. Okay? This one is a skin infection caused by excessive proliferation of Corynebacterium minituziosa. Okay? Predisposing factors include, you got a guy in a warm, humid climate, doesn't take his damn showers, so he's got that poor hygiene, hyperhidrosis, so sweating, obesity, diabetes, advanced age, or they're on some type of a medication because of immunosuppressive. So they've got those things of the comorbidities that are out there that can elucidate and have this flow. Okay? With erythrasma, I got something right here that is bold. Boom to the boom. It's red. Coral red. We talked about Pseudomonas. If I put the Woods lamp on Pseudomonas, its color is what? Green. If it's erythrasma, it'll be coral red. That's different. Y'all will see the pictures. Promise. So, with erythrasma, most common site is the fourth interdigital space. So that's that same of a Pseudomonas, right? Between the fourth and fifth toe, fingers, those areas. Also in a bilateral inguinal area, so of the axilla, of those folds, of the scrotum, of the vulva, like it can be down into those areas. Key component is that next bullet right there. Does not spare the scrotum or labia. Once we get into the fungal stuff that we're going to talk about after this, there are tinea of the groin. Doesn't go onto the scrotum. This one does not spare the scrotum. So it's onto the scrotum. So if you were to see a picture, you put a Woods lamp on it, you see that coral red, and it's on the scrotum, then erythrasma. If I'm showing you the same Woods lamp and it's fungal, it will spare the scrotum. So that's out there. You'll see. Again, it itches, it burns, ouch. Macular brown, red, scaly, non-inflammatory. Coral red. Keep the area dry. Topical. We'll use some type of erythromycin. We'll use clindamycin. That topical, okay? If it's severe or if it's not working with the topical stuff, we'll get into systemic erythromycin or clarithromycin. Basically, you're going to pick a mycin, okay? Is it going to be topical or is it going to be oral? Depending on what it looks like. Again, talked about it can happen in that area. If I were to put a woods lamp, would I see that coral red on the vulva?
Yes.
Yes, I will. If I were to put that woods lamp on this right here, right now, we would see that on that labial area. We can see that in between of that 4th and 5th space. We can see that on the axilla. Those pictures at the bottom, of course, we can see that's a man, right? We see that coral red of that scrotum and of that inguinal area there. But we put the woods lamp, it's there, okay? You can see that redness on the woods lamp is in all of that area. If this was fungal and we put that same woods lamp on, it would not be on the scrotum. So if it's on the scrotum, yeah. Get off my scrotum. Okay? I always come up with fun stuff. You'll remember. You remember. All right. Last ones. Pitted keratolysis. Multiple 1 to 3 pits to weight-bearing areas. Okay, so this is basically the bottom of your feet. Okay, so you've got that stuff, the weight-bearing. Okay, if you're always like on your feet, if you're standing, if you're walking, if you're running, like, yeah, this could be one of the things that have to be treated after a marathon. Caused by Psittacosis sedentarius, which produces enzymes that digest keratin. So they got that hyperhidrosis observed, malodor, it's slimy, okay? Tropics, right? So are you in those humid, moist environments out there? Overuse of occlusive footwear. So your soldiers are out there, don't ever take off those boots, okay? So it's constantly like that and you're in that wet environment. So clean daily, promote dryness, change socks, rotate footwear. Topical wise, we'll use some of that erythromycin ointment or clindamycin solution, so we're soaking those. Dry sol, we talked about the hyperhidrosis. If, let's say, you have one of your soldiers or airmen or sailors or coasties, they come to your TMC and they have already tried this and that and back and forth. Their roommate in the barracks are saying your shit stinks. Okay, if they're not working with that over-the-counter stuff, then we'll prescribe. We'll start on that oral erythromycin. Okay, if the topical's not working, then we're going to do oral erythromycin. What do they look like? So you can see that pitted, right? You see that on of the feet. Again, weight bearing. You've got those spots that are pointing it out. This individual has it on of the heel, but also has it on those soles or of that metatarsal head area, okay, the weight bearing that occurs. Again, you can see those, okay? So, if this airman comes in, they've already tried over the counter, the roommates are saying they smell like shit, it's horrible, okay? Oral erythromycin. That's what we will want to treat that with. And we went through all that stuff, right? Impetigo, bullous, non-bullous, cellulitis, right? We're going to IND that stuff. Erysipelas, blistering, IND, folliculitis, you know, furuncle. If there's more than uncles, then they're in the car. Carbuncles. SSSS. And then we're going to add that fifth S, right? Pseudomonas diabetes. Pseudomonas diabetes. What's that other word? Name? Cipro. Okay, and then it goes into the white, erythrasma, off my scrotum, pitted keratolitis, erythromycin. Any questions? All right, it is 10:50, but then we're going to get into those of the yeast, of the candidus, stuff that is out there, okay? Like I said, so, dermatophytes, okay? That's that group of the fungi that infect the stratum corneum, so that keratin area that is where this happens at. So it's there. We can also have this on of our hair, of our nails. We got the fungus out there, okay? So it's out there. Responsible for the vast majority of skin, nail, and hair fungal infections. These can be, some type of a ringworm, right? I told y'all how when I was diagnosed with my psoriasis, first that specialist with my TBI clinic thought that I was having fungus on my head, and it wasn't. And so that's why that can be those things. Ringworm, we've got Microsporum, Trichophyton, and Epidermophyton. Yeah, those things out there. Again, breaks it down, okay, into of the tinea, where it's at, where it can, what is the skin that is happening. That Trichophyton rubrum is the most common one that is out there. So tinea, fungal infection. We can have it of the head, the face, the beard, the body, groin, hand, foot, nails. So it breaks it down into all of those areas, right? So capitis, that's the head. Facial, beard, barbae. Corporus, that's that body. So that's of our trunk of those areas. Crurus is of the groin. Okay, so that jock itch. We talked about how this tinea is going to spare what? Spare that scrotum, spare that vulva, spare that stuff. Of the hands, of the feet, yeah. Gotcha. Modes of transmission. So how do we get this fungal stuff passed around? Well, human to human. They can, buy or get a new cat, so that animal. Soil to the human. Fomites, so clothing, furniture, gym equipment. Y'all go to the gym and you wipe it down with that wipes afterwards, right? Sometimes individuals wipe it down even if they're just walking into it because they don't know if the person before them actually wiped it down. So there we go. So tinea, morphology. You get that ringed annular lesions, raised scaly borders, central clearing, so that's why it's called a ringworm, right? Because you can see that ringed border, and then in the middle it looks like it's normal. It's just wrapped around. Normally papules, plaques, but occasional pustules, vesicles, erythema with flaking. So if it gets worse, then you can have those other things that happen. So with these fungal aspects, these dermatophytes, it's not a clinical diagnosis. We're only looking at it and saying, oh yeah, that's a ringworm. Okay, that's fungal. No, we do of a KOH. We get culture. We get Woods lamp so that we can prove of that clinical diagnosis. So with KOH prep, we're going to scrape with that a 15 blade at the active border. Look like branching fungal hyphae that are uniform in width. And then we'll send out that dermatophyte test medium. Once we put that into the culture, we'll see that red 7 to 14 days of dermophytes present. Woods lamp, typically we're not going to see that erythrasma, that coral red, when we use that woods lamp. That shows us that erythrasma. When we use woods lamp and it is fungal, we're not going to see that. Okay? Only if it's versicolor. So that's that scrape, right? That 15 blade. Put that on the scope, and we see that hyphae that happens there. So now we're going to break it down and we're going to talk about all of the different areas that these things happen at, right? So we're talking about the core first. So the corporus, that's that trunk. So neck, chest, belly, back, that's that corporus area. So superficial lesions, topicals work. Okay, so we can use all the zols. So clotrimazole, miconazole, ketoconazole, terbinafide, naptopine. We use that 2 to 4 weeks, twice a day. And once that red is gone, right, oftentimes, and y'all probably went through this in all of the farm that y'all went through, a patient, oftentimes, if they feel good, they stop whatever it is that you've given them. But it's always recommended that they continue those things after. Go through the entire medication. Even if you feel better, still do it. So with this one, we're going to use that another 7 days. Once that redness is gone, still use it because it can come back. With tinea corporis, okay, if it's extensive, if it's deep, we're going to get into a oral agent, specifically talking about PO terbinafide, itraconazole, fluconazole. A key component, and we can, like, you've got peds after me, okay? Let the kids rise. Let the kids rise. Cries. So if you're having a fungal thing and we're going to be treating a child, let the kids rise, because we're using Grise. Grisafluvid. Okay? Let the kids rise. That's what they look like. Okay, of course, it's on that trunk area. You can see that ring, right? So you've got that clear in the middle. Clear in the middle. But it's got that outer aspect. Again, there. Okay. So tinea corporis. If it's deep, use an oral. If it's a kid, let them rise. Tinea pedis. So that's the foot. Keep the foot clean and dry. Topicals, if it's interdigital, so it's not just on that outside of that, it's in between the toes, then we can use terbinafide. In bold, we see moccasin, right? So if we have that and it looks, it's more of a Indian footwear, right? If it's a moccasin, then we're going to be doing some of that oral. Moccasin means what? It looks like you see that fungal aspect that's coming up and out of the foot. Okay, so it looks like they have that sock on. If it's spread and it looks like they have a sock on, then we're going to use that oral type. Terbinafide, itraconazole, fluconazole, terbinafide, moccasin fine. So we can see this here, okay? We've got that interdigital and some of that, but we've got it, you know, also on of the lower of the feet and da-da-da-da. Okay? Interdigital, we'll use that topical. Moccasin, y'all can see this, right? Moccasin. So it looks like he's got the sock on because we have fungal that's all down here, but it's getting into the top of the foot. It's on his ankle. It's up there. So he's got a moccasin-like. So we're going to use turbinify. Okay, so this is up here. Some other areas. So we've got the manuum, that's that hand. Barbae, that's that beard area. Fascia, okay, that's on of the cheeks. It's, you know, up here on of the face. Break it down there. We can see if we're talking about the hands, that's most common in men. Is we treat it just like we did with the feet. Okay, it's the same thing. Barbae, treatment with oral agent only. So if it's in that beard area, meaning if it's on of our neck, if it gets in our chin, lower cheeks, so that beard area, then we're going to be using that oral. What was one of those oral things that I talked about? Yep, turbinify. Okay, so that's out there. Facial. Okay, so that's of that upper cheeks. Specifically, we can use typical stuff there unless it's close to their eye. We're not using topicals if it's near the eye. So if it's an adult, we'll use, so if it's near the eye and an adult, then we'll use turbinify. If it's a child close to the eye, we'll use Grise. Okay? Good. Y'all are good. Y'all got this. So there you go. That's the hand and the foot. That's that barbae. So if we see some type of a picture shows that area, then we're using that turbinify, right? So we're using that oral. If it's a child and it's near the eye, then we're going to Grise. Again, not topical if it's near the eye. We're going into oral. So turbinifying adult, Grise, kid. So here's the crurus. We talked about erythrasma on the last lecture, and we talked about how that coral red gets on to that thigh, to that area, but also onto that scrotum. This one, if it's fungal, typically spares the scrotum and labia. Okay, so it's not going to show it onto that. Okay? Again, erythrasma, that's that coral pink color of the woods lamp. And erythrasma does not spare the scrotum, whereas tinea does. Treatment-wise, we're going to keep it clean and dry. We're going to be using some of that topical clotrimazole, miconazole, ketoconazole, zols. Extensive refractory is the same thing as the tinea corporis. So if we need to get into of an oral agent because it's extensive or it's deep, then we're getting into turbinifying. We're going to go into Grise, right? So those are those things out there. Okay. Again, picture-wise, we see it's in that intramural groin area, but not onto the scrotum. And again, those areas. Capitis. So that's that head, right? We see this most common with those children. Ranges from mild scaling and broken off hairs and extensive involvement with alopecia. We can have this remain viable for long periods because they're using the same combs, the brushes, the blankets. They're just building it up and letting it stay. Even if they try to treat it, they're still going to be exposed to it because they're using those same damn things. Okay? For patterns of infection, so they got that black dot type most common. So you'll see that black dot. One of the things that we oftentimes do to have this diagnosis is we're going to go through some of the culture. We use that of a toothbrush, right? We scrape it away and then pound it into that culture so that we can look it in the woods or look it in the microscope so that we can see that. And we'll show that picture in a bit. If it's tinea capitis, okay, must treat with systemic oral agent. So we're not talking about anything topical here. So tinea capitis, if it's a child, we're going to do what? We're going to rise. We're going to rise. I always just say rise. Like I want to rise a child, you know. Da, da, da. Okay. Adults, we can rise that, but terbinafine is pretty much what we would treat for that individual. That's what that culture technique looks like. You take that toothbrush, smack them in their head, hair, and then put it into the culture so that we can see those things, okay? That's what it looks like live in person. So we see that black dot, we see that yellow crust, we see those things that are just showing that, and it's causing them to have that alopecia, so that hair loss, because the fungus is kicking it out. Again, da-da-da. When we get into the scope, we see those black dots, right? So we see of that fungus that is down there. So that's that. Carry on. So this is that tinea capitis inflamed, like it's worse, it's severe, it's great. Okay, so this is that inflammatory tinea capitis. So it's painful, tender, boggy, drainage. There's that stuff that's out there. This will cause some of that same alopecia that tinea capitis is. This is just more severe. You can also have fever, you can have adenopathy, you can have those things. We'll do that diagnosis, of course, with that KOH. It could be negative, but we know that it's that capitis severe aspect. So if it is a carry-on, then we're going to treat with oral antifungal. So we're going to rise or terbinafine, preferred. If it's, you know, very bad, which we're going to see in the picture next, then I'll also add in some of that oral steroid to reduce that inflammation that is in there. So we're treating it antifungal, but we're going to do the inflammation of a steroid as well. And that's what it looks like. Okay? No, boy, no. Okay. The last of the tinea is incognito. Incognito. So this is a fungal infection treated with topical steroids. So it's because of the steroid, they're having that fungus that is having a ball, like they're having fun. They're out there playing it. So alters characteristics of fungi. So margin scaling often absent, diffuse redness, erythema, scale, pustules, absence of border. Inflammation improves while fungus flourishes. So they're using some type of a topical steroid that is causing that fungus to be at a party. Okay? They're loving it. Most common on the groin, face, and dorsal hands. So the fungus is happy, incognito. There we go. And again. So that's all that fungal stuff. Now let's get into the yeast. So Candida albicans or other ones that are prevalent in normal flora. Opportunistic infection, favorable environment. So they're in a environment of warm, moist, dark. Okay? Becomes pathogenic with damage to the stratum corneum and pre-existing condition disease. So They have diabetes, right? So they're having some yeast infection because of the fact that they're having those underlying disorders. So pregnant, diabetes, maceration, they're on an OCP, they've been on some antibiotics, they're on some topical steroids, so they're on immunosuppression, they're on things that are just breaking them down and letting the yeast have a party, okay? We can have these happen anywhere, okay? We've talked numerous times about that intriginous, so that skin folds, right? So up and under the belly, up and under the breast, the axilla, the groin. We can see that diaper yeast. Interdigitals, so toe web spaces. Balanitis, so that's that uncircumcised men who don't appropriately bathe, shower, clean. They don't pull that foreskin back, don't retract it, so it just builds up in that moist stuff, so that can happen. Paronychia, so the nail folds, right? So you can get it up and under the nails. But we also have oral, we have angular cheilitis, we have vulvovaginitis, so that groin area. These are the distribution areas that we can have that yeast infection. Clinical, yeah, we're looking at it. But if we're going to be doing some of that KOH prep, then we'll see that Pseudophae budding spores. Keep it dry. If you got it, I'm going to treat your partner as well, because you might be passing it back and forth to each other. So, yeah. There's that budding yeast, okay? With yeast, Candida, budding. Treatment-wise, it depends on what distribution is at. So where is the yeast at, and how will we treat it? Well, if it's vulvovaginitis, then we'll use fluconazole. Okay? That's that oral stuff. Topical-wise, we can use that azoles or nystatin, so clotrimazole, maconazole. That's that. So that's of the vulvovaginitis area. Well, how about if we're having it in our mouth? Well, then we can use that nystatin oral suspension. So that's that Trocia, right? That small medicated, yeah, it's of a drop, right? So we're going to just put that in there and let it dissolve in of itself. So it's a gumdrop. Lollipop. If it's angular cheilitis, so that's that Joker streak that we oftentimes see on the corners of our mouth, we use that topical antifungal followed by group 5 steroid. Discontinue that steroid once that inflammation is gone away. We will, yeah, so we'll do that there. More some stuff. So there's that intrigo, diaper, balanitis. So I talked about balanitis is that swelling inflammation of the penis glands. So that swells up. Oftentimes these individuals are uncircumcised, right? So they have difficulty retracting that of the foreskin, yada yada. So hygiene education, consider wet dressings, topical azoles. So BID. Azoles is pretty much all of the treatments for fungal stuff, is those azoles. Maconazole, ketoconazole, clotrimazole. Y'all have seen me already write test questions that have medications in there. I will not have multiple zoles in there, because you could pick all of them and then it would be pan credit and all be perfect. Okay? So azole will be in there. That's that angular cheilitis. I talked about that Joker, right? I always think about Batman, right? That looks like the Joker. That's that angular cheilitis. Oral, right? So I talked about those lollipop. So you got that yeast that's located on that uvula. You've got it on that post-nasal area. Again, moist areas, right? So those intra-inguinal areas. Groin, diaper, up and under the breast, groin, balanitis, so you got that redness, you got that swelling, inflammation of that balanus of the glands. Rectal area, yay. All right. Pityriasis tinea versicolor. Overgrowth of yeast. So this is still some of that Canada stuff. We talked in block 1 about malassezia for fur. That was an answer yesterday, was it? So these things are out there. Normal skin flora resides in the stratum corneum and that area of the damn skin. Hair follicles prefers highly sebaceous areas, so those sweating areas. Hot, humid climates, so you're on vacation in South Florida, somewhere on the East Coast. Begin as multiple oval and round macules in various colors, so it can be white, it can be brown, it can be pink, it can be anything. Typically turns darker in lighter phototypes, so Caucasians, and lighter in the darker phototypes, so those darker, yeah. Superficial flaking with mild fine skin, enlarged rapidly. Usually asymptomatic. It can itch if it's got some of that inflammation that is out there. But mostly with pityriasis versicolor, that patient's coming to see you to say, what the hell is this, right? So that's that pityriasis versicolor. Patient concerned about that. Most common site, mid-chest, upper back. So mid-chest, upper back. We can have it in that antecubital fossa, the neck, extensive eruptions of the upper arms and lower face. Facial lesions are more commonly seen in that. Diagnosis-wise, Wood's lamp may extenuate areas of altered pigmentation. So if we're going to use that there, then we can see those things. Okay? We can see that 15 blade again that we're using for the fungal stuff. We're scraping that stuff away so that we can then send it out for KOH. We can do culture. We can do those things there. Okay. Key component: bold spaghetti and meatballs. Spaghetti and meatballs. And I'm going to show you the picture, and it does damn look like spaghetti and meatballs. When you look on the scope slide, spaghetti and meatballs looks like pityriasis versicolor. You can see that. Okay, yeah, you can see some of that spaghetti strings. You can see those meatballs that are there. That's what the slide looks like. We'll have another picture coming up in a bit that even looks more like spaghetti and meatballs. But spaghetti and meatballs. Topical agents. So ketoconazole, 2% shampoo. So applied to the whole body. You stay in that shower for 5 minutes while it's absorbing all of that kind of stuff, and then you wash it away. Use for 3 days. We can also use some of those over-the-counter stuff. But I will stick with ketoconazole shampoo because y'all are physicians and y'all will prescribe stuff. Okay, so yes, OTC stuff is out there, but ketoconazole shampoo, leave for 5 minutes and wash it away. If it's more extensive, then we can get into some oral agents. Again, we're getting into ketoconazole, itraconazole, fluconazole. Basically, azoles are out there. Once we do treat them with some oral stuff, we're going to give them the shampoo also. So use the shampoo after so it doesn't reoccur. It doesn't come back. Okay? If you have a individual who's had this pityriasis tinea versicolor over and over and over, just keep the damn ketoconazole shampoo in your shower and use it once or twice a week just to prevent it. Okay? That's out there. So talked about that trunk. Again, you know that this would be of a differential diagnosis of the block 1 stuff, right? Because what do we see in block 1? What was the Christmas tree? Yeah, it looks like this or too, right? So it's similar. So those are one of those things out there for you to do. Okay? Again, upper back. Upper back of the face. We use that 15 blade, you scrape it away, KOH it, and look at it. And this picture, this one is absolutely spaghetti and meatballs. Like, it looks like it. Okay? So that's that. Last one. And then we'll be off to lunch. Sporotrichosis. Look at that. Ugh. Okay? So this is that saprophytic fungus. It's a subcutaneous infection. Key component is most common found in florists, farmers, hunters. They feel like their hand was pricked by a rose thorn. So they're going down and up and under some stuff because they're working. Ah, damn, that hurts. And then it starts to go fungal wise. Okay? Florist. Initial lesion, painless, papule, like they see something happen, but it's not really hurting that bad. And then it develops, and that fungal yeast shit spreads lymphatic, right? So the most common site is if it's happening in fingers, right? So I'm going into something and I prick, I get that thorn, and then I start to notice that it's spreading and I'm starting to see skin stuff in a lymphadenopathy area, so a location. So it spreads in those lymphs. Punch, biopsy, excision. We're going to do some of that microscope. We're going to do culture, okay? Differential diagnosis stuff. Cat scratch fever. Dun, dun, dun. We got TB, tularemia, syphilis, okay? Other things out there, okay? If this farmer is having this, we're going to treat him with one damn thing, and that's it right there, itraconazole. So we're going to treat them that once a day. And it can take time, right? Because it's that lymphatic spread. So how far does it go? Again, their initial lesions could be on the tips of their fingers. It could be somewhere on their hand. But then it's going to spread and it could run to those other locations, as seen in these photos here. Okay? Specifically, I love this picture because it shows you. It starts here and it's running all the way up. So it's in that lymphadenopathy area. So this individual worked, and then it ran all the way up. Now I'm going to treat them with itraconazole. Again, that's that lymphadenopathy area that it flows to. So that damn thing loves jumping those beans. All right? That is it. So we talked about all of the tinea, right? We talked about the hair. We talked about the face. We talked about the groin, back and forth, and da-da-da-da-da-da. We got into that yeast, tinea versicolor, and that sporo that is out there. Any questions? All right, we'll be going through tomorrow.